to the third one, Dr. Sagarika Patial. Hello. Hello, Dr. Patial. Please come in, and Dr. Sagarika will be presenting on indication, results, complication of Ahmed glaucoma valve along with ocular procedures. Can we get her talk? Yeah. Thank you.
Thank you very much. Since it's 5 minutes, I'll begin. So we have talked about, this is a non-comparative series of various types of glaucoma in which we did Ahmed glaucoma valve along with other things also. So we know that what is an Ahmed glaucoma valve. I have shown one where we have put it into the anterior segment and one from the posterior segment. These were the case series from 2020 to 2024. And in 2020, of course, we had very few cases, retrospective analysis of our own cases of 22 eyes implanted with either anterior or a posterior tube implantation for various ocular disorders. And it was a single procedure or in conjunction with other procedures or following some procedures. Number of patients were only 22. We had males 17, females 5. Age range was vast, between 55 and 75. We had 3 one-eyed individuals who underwent AGV. Now, preoperative IOP ranged between 27 to 56. Whenever there was pre-op raised, IOP was treated with acetazolamide 3 times a day, brimonidine with timolol and dorzolamide. If IOP did not reduce to a normal level, approximately normal level, then we gave injection mannitol prior to surgery. We had to do, in all cases of NVG, PRP and an anti-VEGF was given. This was done by the VR surgeon. Now, the Ahmed glaucoma valve, which was used in all cases whether it was anterior or posterior, was the FP7, made up of medical grade silicone, overall length being 41.4 millimeter, which is very important, plate length being 16 millimeter, surface area being 184 millimeter square. Types of systemic comorbidities, diabetes was maximum. Amongst others, we had diabetes and hypertension in 2, and coronary artery disease, which is very important, in 3, and the rest, of course, UTI in 2 lady patients. NVG, because of the etiology of the cases, were mainly NVG due to diabetes mellitus in 10 cases, and then we had NVG with CRVO, and of course uncontrolled because of uveitis, post-silicone oil-induced uveitis, post-VR surgery due to RD, post-trauma, severe trauma with secondary glaucoma, post-ACIOL, and post-central retinal artery occlusion. Types of surgical procedures were AGV with tube in the anterior chamber, tube in the vitreous cavity. 17 were in the first, 4 in the second. AGV we did with scleral patch graft in 20 with a lenticule, 2 lenticules, corneal lenticules in 2. The others, of course, with cataract surgery. AGV with PPV and endolaser in 4 cases where we put the tube in the posterior chamber. AGV with glued IOL in 1 and with scleral fixated IOL and anterior IOL in 1. I'd like to just show you the type of surgery that was done. It's the simple same thing which we do in every case, and after nicely dissecting it, priming the valve, putting in the valve, and after that suturing it, and that's about it, and then putting the scleral patch graft, and then we have the next one is tube in the posterior chamber. This was a special case where it was one-eyed 75-year-old male with ACIOL, and mitomycin was done with, and we did an AGV, PPV, endolaser tube in the vitreous cavity. And this was a very, very tough case. But then again, and you can see that I have made the, even holding the superior rectus was very difficult. I made an incision much behind than what we make. And you can also see the the glued IOL. And of course, the rest of the thing is the same. And where the tube had been, where the PPV had been done by the VR surgeon after doing the vitrectomy and then the laser, after that, of course, we put it in the same port as the VR surgeon had made. Surgical technique has already been described. And posterior fixation of the tube was done. In this, we always try to make a scleral fixated, partial thickness flap, and after that again put another partial thickness flap. But in one case, we could only cover the tube with the scleral patch graft. In 2 cases, the AC placement of tube, the scleral part of the graft was covered by 2 corneal lenticules. Severe trauma, we had 2 cases, and here we have where I will just show you a little bit of the how we put in, this is after putting in the tube. Now we were doing a scleral fixated lens, and this is the aniridia lens which was implanted into the eyes. And this patient has done very well. It's 2 years follow-up now. And post-operative vision, we find 2 patients did not regain any vision. One patient had uncontrolled diabetes. He lost his vision after surgery. It was his only seeing eye after AGV and PRP anti-VEGF. On 2 years follow-up when he came, he had lost his vision. Second was a case of CRAO, where we had to do this procedure because the patient had extremely high intraocular pressures. One was a case of, third was a case of chronic angle closure. She had a mature white cataract and had neovascularization of the iris, which is unusual in the case of angle closure glaucoma, therefore being presented, and did not regain any vision.
Dr. Sagarika, do you
Yes,
want to?
That's it. That's it. Complications we've seen, a tube erosion, repair with, and of course partial thickness graft, and hyphema we had in one case.
Thank you, Sagarika. I think nice
Thank you
case.
very
What was your primary outcome? What do you want?
What the primary outcome, these were varied cases, Dr. Pandav. And therefore, it's very difficult.
But the
study itself is showing us that even if you have the most difficult cases, you read these procedures with the help of your VR surgeon.
To define that you are successful, I mean, you looked at the IOP, or you looked at the visual acuity, or what is the main parameter?
IOP. Most important is IOP. Yeah, the IOP was reduced.
Okay, so I was wondering, some of your cases, you actually had multiple procedures. Like you had AGV, you also had the cyclodestructive procedure done. So in that case, how would you attribute?
We didn't have any destructive procedure. What we were doing was only that suppose a patient could not be taken up for a PRP earlier, pupil was not dilating, the patient's condition was such, and so these are all patients who come to
There was no case where you did AGV with vitrectomy and cyclo.
No, it was only the removal of, doing a PRP on the table.
On the table. Okay, thank you very much. Any questions from anyone from the audience?
Dr. Sagarika, have you used mitomycin in any of these cases? There is conflicting evidence regarding the use of mitomycin for Ahmed valve.
Sir, we have used in some cases, very few of them, because I've found that without it also it works very well. But in those cases where we found that first of all, I definitely exclude that the patient is not myopic. And second is that we know that the patient may have a higher rate of failure, the patient is only one-eyed, then we use a very, very dilute, only 0.01% per milligram per ml. We just use it for a minute just to help us out.
That's the homeopathic dose.
I don't know whether, it's
that's a homeopathic dose.
No, but the thing is that Dr. Ramanjit Sehota has showed that 0.01%
Thank you.
works.
Thank you. We can go to the next.
Thank you. Thank you, sir.